The broadcast is now starting. All attendees are in listen-only mode.
Good morning, everyone. This is Deanna Mitchell with Leading Age Michigan, and we would like to welcome you all again to our October 14 Safe and Calm webinar. We do have numerous updates today, and as usual, we have placed the nursing home only content at the end of the webinar. Today's agenda is a bit different. We'll be starting this morning with a presentation from Robert Boonin, who is an attorney with Dykema Gossett. Dykema has been a great resource to our members during the ongoing pandemic and during usual times as well. Robert works with the Dykema Labor and Employment Group, and we'll be talking about recent clarifications for the Family First Coronavirus Response Act. We'll then follow with a brief legislative update from Dalton and follow with our usual updates. So at this point, we'll turn it over to Robert. Welcome, Robert.
Good morning, and thank you for asking me to attend. It's a pleasure to be here again. We're going to cover some recent developments. The DOL has been pretty busy for a number of reasons lately, and it's issued a few more regulations, a few more guidances that I think are relevant to employers as they're kind of adapting to the new normal. I'm going to go through them rather quickly. We are limited in time, and it's a challenge for a lawyer to limit himself in time or herself. But I think I'm up to the task. So I'm just going to jump right into the materials if we can. Here, I'm not sure. There we go. I do have control. So we're going to discuss some of the new regulations under the Families First Coronavirus Response Act. And there are new regulations that came out. There's new guidance about how we're dealing with school openings. So employers are still grappling with how to do that smoothly and well and in compliance with the law. Then there are other issues in terms of, well, schools are reopening, but what are the other leave issues that we're going to have to deal with? And there's also new guidance about how you deal with remote work and to keep track of time and paying employees appropriately, paying them for any overtime work and so on. Now, the reason why there were new FFCRA regulations is because there was a challenge in a federal court in New York. The state of New York challenged the DOL's regulations, stating that the DOL, or claiming that the DOL really went too far, went beyond what it could do in using its regulatory authority in the way that it carved out its regulations. And they challenged 4 regulations before the court, and the court pretty much sided with the state of New York earlier, in late August. And then we were waiting for a while to see what the DOL was going to do about it. Did the DOL think that this decision was just limited to the jurisdiction of New York, the jurisdiction in the Second Circuit Court of Appeals, or did it have nationwide effect? There was no injunction. So we were kind of in a state of flux for a while. And finally, just a couple of weeks ago, the DOL responded. And instead of appealing the case, which it can still do, but it's probably unlikely at this point, it decided that it would try to rewrite the regulations that were challenged and conform them to be consistent with the judge's order, or to at least address the judge's concerns. So the first issue that they had was there was a rule, you all know, that if an employee is unable to work or telework because they're need to be off due to the COVID reasons for childcare or for closing of daycare, they could take leave under the FFCRA. But the question is, well, what happens if the employer, after the employee starts taking leave, then eliminates the job and determines that, well, it doesn't matter that the employee can't come to work, we just don't have enough work available for the employee, and therefore we're going to furlough the employee. So when that happened, we had an unusual situation. Well, that seemed to be the conventional wisdom, but the judge said that was going too far, that the DOL did not explain why someone who was on leave all of a sudden could be taken off leave and no longer get the pay, even though they would otherwise be furloughed. That seemed to be a nonsensical part of the decision, in my humble opinion, and I think the DOL agreed. Instead of saying, okay, Judge, you're right, what the DOL did is that they rewrote the regulation and its rationale for the regulation, but the outcome was just still as it was. If you would have been furloughed anyway, your right to the leave stops at that time. So that was what the rule was under the old regulations, and notwithstanding the judge's order to the contrary, the new regulations still allow employers to do what I think most people would say would be the only logical outcome in that particular situation. Another issue that the court had to deal with was a requirement that the DOL had in the regulations that in addition to telling an employer that there's a need to take a leave under the FFCRA, give the employer prior notice. Before taking the leave, the regulations said that the employee also had to document the need for the leave, give the medical documentation or the proof that the school was closed and so on. And this one, the DOL basically wrote the regulation to say, Judge, yeah, you're probably right. You know, we don't need the documentation as long as we get it soon after the leave begins. We have it's like when you ask for an FMLA leave, the employee still has a few days to get documentation to the employer. And that same rule will apply for documenting the need for leave under the FFCRA. The third issue that was challenged before the court was the rule regarding the use of intermittent leave under the FFCRA. And the DOL said that, well, unlike intermittent leave under the FMLA, where the employee and the employee's physician basically determines that intermittent use is going to happen if it needs to happen. When the leave is taken under the FFCRA, it's only to be taken according to the original rule. It's only to be taken when the employee and the employer agree that it can be accommodated on an intermittent basis. But here, unlike the regular FMLA leave, this leave is paid, and also unlike the regular FMLA, this leave really is implicated when there's some public health concern about should the employee be coming in and out of the workplace if they have someone who is ill or showing symptoms, or if you're trying to protect the sanctity of the workplace, at least health-wise. So the court, though, said that there's nothing in the FMLA that supported the addition of having the employer having basically a veto on whether or not intermittent leave would work in a particular situation, and it's therefore struck down that rule. Instead of conforming it to the court's decision, the DOL addressed the court's concerns about not having sufficient rationale. So basically it beefed up the rationale and promulgated the same regulation, essentially, that for leaves under the Emergency Paid Sick Leave Act or the Emergency Family Medical Leave Expansion Act, leaves taken intermittently are only to be taken when the employee and the employer agree that intermittent leaves make sense and are appropriate. So last but not least, and perhaps I guess the one that caused the greatest gasp amongst the people at this webinar is the healthcare provider exemption in the DOL's original FFCRA regulations. As many of you are probably aware, the DOL had a very, very broad definition of what a healthcare provider was for purposes of FFCRA leave, that it's not just to include the traditional definition of a healthcare provider of the FMLA, which is basically doctors and psychiatrists and psychologists, social workers, and people who are authorized to basically sign an FMLA leave form. It's basically any employee of an employer who employs those types of healthcare providers. And the DOL did that because they thought, well, once you are working with healthcare providers, the system needs to operate. So the system needs more than doctors. The system also needs nurses. The system also needs lab techs. The system also needs housekeepers and dietary workers and administrators, in order for the system to work. Now, it wasn't a requirement that the employer could exempt all employees if they employ any healthcare provider, but they could pick and choose among the employees that they would exempt from the FFCRA leave requirements. The court said that's just way too broad and could deal with absurdities, and the absurdity that they cited, which I thought was an absurd cite, but no, I'm not denying that the definition was broad. It included janitors and everyone. But again, if you don't have janitors, then the healthcare providers can't provide good healthcare. But they're saying if you're an academic institution and you have a university and the university employs English professors, then you can exempt English professors. I don't think anyone interpreted it to go that far, but that's the absurdity that the court pointed out. Was, I guess, within the scope of the logic of the DOL at that time. So again, the DOL, I think, swallowed its pride a bit, and when it addressed how to respond to the court's decision, and it greatly narrowed what it would allow employers, who the employers could exempt going forward. And instead of basically anyone that is employed by an employer that employs healthcare providers, it's basically limited to the healthcare providers as defined under the FMLA, that is those that can sign off on an FMLA form, and other employees who are directly involved in the healthcare services, such as those providing diagnostic services, preventative services, treatment, some of the lab support, those that are integrated with the provision of patient care, and not everything that's related to running the nursing home or the healthcare institution. So this means that a lot of people who previously could have been exempted under the old regulations suddenly are no longer exemptable under the regulations, and now we have to make sure that our policies are conformed to adapt to this, so that these employees know what they're entitled to. Now, whether or not this goes back retroactively, it's really too early to tell, but right now we doubt that that's going to be a serious issue for many employers. So what else has been going on? Well, kids are going back to school, and now we have to decide, well, if a kid is in school, does that mean that my employees can stay home for the time allowed and get 2/3 pay, which is what both the Paid Sick Leave Act and the Emergency Family Medical Leave Act, Expansion Act allow. So when do employers, and these are employers with fewer than 500 employees or any public employer, when do those employers have to allow an employee leave time for childcare, basically dealing with the fact that the kids are at school? When do they have to provide this leave and pay the employees 2/3 the pay rate? I'm not going to go into all the details about this. You'll get the flavor of it as I move through. But these are a few hypotheticals, just three I want to run through. And the first one is when the schools are in a total remote learning schedule. So here, the employee's child attends a school that's starting with a remote learning schedule. The school will evaluate circumstances and make a decision on an ongoing basis about in-person learning, as the year develops. At this time, though, is the employee entitled to paid FFCRA leave? And the answer is yes. Here there's the classic situation where the only reason the child is home and and doing school from home is because the child has no opportunity to go to school. So here, as long as the school remains closed, and assuming other requirements for the FFCRA are met, the employee can stay home and get the 2/3 pay. And that means that there has to be no other suitable person available to be with the child at home. So there can be inquiries going toward that. And that the employee is actually to care, leave is actually to care for the child. If the child can work independently, then that's not a good reason for a leave. Also, you got to remember that, you know, the employee still can do, if the employee is able to work remotely, the employer can require that. So that's the classic situation. The next situation is where schools are open, but it's up to the parents basically to decide: are we going to send the child to in-person school, or are we going to adopt a remote instruction model for our child? And in the case where the employee in that situation has chosen remote learning, the question then is, well, now the employee is home because the child is home, but is the employee entitled to leave under the FFCRA? And here the answer is no, because the school is not closed. The child is at home only because the employee has chosen to keep the child at home. And the school is otherwise open. It's a free choice to the parent. So in that case, there's no paid FFCRA available to the employee. I'm not saying that you can't give leave for other reasons or unpaid leave, but it's not paid leave under the FFCRA that the employee is entitled to take under those circumstances. Now, if the child has some other reason to be home, like isolation or quarantine, then the other parts of the FFCRA come into play, but it's not because they're home because of remote learning. The third scenario is when schools are open on a hybrid basis, where your child goes to school, let's say, on Mondays and Wednesdays, and does remote learning on the other days of the week. And you know, there's all sorts of scenarios of hybrid. So here the child is doing remote learning, has no choice to go to school on some days, but has a requirement to go to school on other days. What does the FFCRA do under these circumstances? And the answer is that under these circumstances, when the child is required or not able to go to school on those days, for that child, the school is considered closed, and the parent, if needed to stay home, can stay home and get 2/3 pay if all the other requirements are met. This is like an intermittent leave, but in this particular case, the employer's approval is not required because this is only because the child is home for the school related purposes, not for health related purposes, and therefore the rationale for an intermittent leave approval by the employer doesn't apply. And the EEOC gives some more guidance about this, and I've given you a site for your reference. Very briefly, recently the DOL also issued some guidance about telework and how employers are to deal with it. And here's some just general principles, and I give you the site for where you can get more information from the DOL on this issue, and how the FLSA is made more complicated by virtue of the pandemic. One is that it's perfectly all right for an employer to require or prohibit telework. It's not up to the employee in general to say, I'm afraid to come to work, I'm not going to come to work, or I prefer to come to work, or the employer to say, no, you cannot come to work, you must telework. That is something that's in the employer's toolbox. Now, you ought to use it carefully. There's personnel morale issues that you have to deal with. There's operational issues that you have to deal with. And there could be ADA issues that you're going to have to deal with. But you can prescribe or require telework. Now, There's also no restriction on employers under the FLSA in that you can adjust hours. Say, okay, well, you can't work because your kids are at home between or in school between 11 and 3, but I want you to get your 8 hours in before 11 and after 3. You can adjust the workday prospectively for employees. You can also adjust pay if you need to. You also have to make sure, though, that if you have exempt employees, particularly exempt employees who are working remotely, or even if they're not, that still their primary duties are the exempt duties that made them exempt to begin with, and that they're not, because of the pandemic, no longer exercising the judgment and discretion. They're still doing the management work or the administrative work that made them exempt in the first place, or at least to a sufficient degree. There's been a lot of questions. Employees are asking for reimbursement of expenses and things like that because they're teleworking, for paper, for printers, and for internet. The law does not require that the employer, at least in Michigan, reimburse the employees for that. That's totally a personnel matter for each employer to figure out how to navigate on its own. And then also, I want to make sure you understand, the law does not require hazard pay to be paid. Now, in the ability to work without a mask, for instance, I have a doctor's note, I don't have to wear a mask, but the employer wants all employees to wear a mask. Does that give the employee the right to say, I need to work, I need to get a free pass and not work with a mask? And the answer is no. We still have a right to protect employees, and if not wearing a mask doesn't protect our other employees, then we still have a right to require it. But we still may have to, if it's because of a disability, we still may have to accommodate it somehow. And we would have to engage in the interactive process and see, well, is there a part of the workplace that we can isolate this employee? Is there an office? Is there a way that this employee can telework? Is there ways that we can adjust schedules to keep it, or otherwise keep it clean? But waiving a mask requirement usually is not a reasonable accommodation. Also, in late August, the DOL issued guidance to remind employers that if you do have employees working at home, and we're seeing a lot of new lawsuits on this issue, but if you do have employees working at home and they're not exempt, you got to be careful. You still have to track their hours. You still have to pay them for all-time work during the workday. Here, they've made it clear that if an employee is taking a couple of hours off to deal with childcare issues, school issues, or just because their favorite soap opera is on or whatever, that can be an unpaid break, basically. That doesn't count as a work hour, but you must require all employees to account for all time work. And if you're getting emails from a non-exempt employee in the middle of the night, you got to wonder after a little while, well, when did this employee take the time off during the regular workday? How is that being documented? So you really have to make sure your time and attendance tracking policies are really up to date, and that the employee is on notice that we want to know every minute that you work. And while we discourage overtime, you're still going to get paid overtime. We ask that you get prior permission, but the law says even if the employee ends up working an extra half hour, you still have to pay that employee the extra half hour unless you like comp that extra time during that same work week. So you have a few options to manage it, but you need a good policy putting the burden on the employee to keep accurate time records, to have a way for the employee to complain that they haven't been paid for all time work and ask them to do that by the end of the following pay period, and make sure that no employee feels intimidated or under pressure not to report all time. And if you do this, you're going to help yourself avoid really reduce the exposure you would have should the employee later claim that they haven't paid for all time work. I can talk about this issue for hours, but unfortunately my time is up. I do want to give you a breaking headline though, and I think this may be also covered by other speakers, but just last week we got a few Supreme Court decisions that limited the governor's ability to issue all the executive orders that she's issued since April. And so we are in a state of flux on some of that. And a lot of those are being picked up by the Health and Human Services Department and other local governments, and there's still federal requirements. I've asked Deanna to send everyone an article that we just published that summarizes how this affects employers that were trying to conform to the old executive orders. What does that mean? And I think you will find that article helpful. So that's it for me, unless there's any significant questions out there. I am available to answer questions offline if you want to give me a call or send me an email. Blake, do we have anything that we need to address now?
All right, thank you very much for that, Robert. As of right now, I am not seeing any questions. So if anybody does think of something after the webinar and they need to get in contact with Rob, you have a phone number and an email right here. And if you end up losing those or anything like that, feel free to reach out to pretty much anybody on our Leading Age Michigan staff, and we will make sure that we get you in touch and get any questions answered. So now I am just going to switch it over, make me the presenter, and then we will continue on. I think, can you see my screen?
Yes.
Okay.
Okay. Well, thank you, Robert, very much. We appreciate your help. And we'll make sure that everyone has your email address if they should have any questions. We're going to turn the presentation over to Dalton Herbal, our Director for Public Policy. He's going to focus on the movement of several bills. During yesterday's legislative session, there was a late night, I understand. So Dalton?
Good morning, everyone. And yes, it was a late night. And as you can tell from our advocacy agenda, it's just talking about bill movement today and the Michigan Supreme Court's response to Governor Whitmer's ask for extension or delay of their ruling until the 31st or 30th, or 20 something, I don't remember. It was rather late night last night. So we'll start off, if you go to the next slide. I don't have a slide for the Supreme Court ruling today, but what happened was the governor asked for a delay of the ruling that would get rid of her executive orders until somewhere near the end of October. The Supreme Court came back and said yesterday that there is going to be no delay, and actually encouraged that their certified question and the orders that they said be filed immediately. So as of, I think, yesterday morning sometime, the executive orders no longer have any legal standing in Michigan. There are still several DH or MDHHS orders that have been issued that Deanna has covered and may be covering this afternoon. What this has led to is a lot of action from the legislature trying to come back in and fill the holes that the executive orders left. And this led to a session yesterday that I think was over 14 long. It went well into the early hours of this morning. So I don't have any particular specific bill analysis this morning, but I did want to give everyone an update on where the bills are, kind of what has came out of this session, and maybe some key highlights, especially for the Senate Bill 1094, as this bill has been rather transformed overnight into something much bigger and something much more specific. So we'll start with that bill. Senate Bill 1094 has turned from a general implementation of dedicated COVID facilities into the COVID care, the CRCs, I don't remember the acronym right now, the CRC bill, with a lot of specific detail in it as to what makes a nursing home provider, what are the eligibility criteria to become them, and it did take immediate effect, and the implementation date for everything within the bill is going to be November 15th, 2020. What this bill says is that that the LARA and MDHHS will need to incorporate the relevant guidance issued by the CDC and the Michigan Nursing Home COVID-19 Preparedness Task Force into a report that they give to the Senate and House health policy committees, and which is due by November 15th. The bill also says that the departments need to implement a statewide policy for nursing homes on providing in-person, indoor, and outdoor visitation to all nursing home residents, except for, but they can limit visitation for residents who have tested positive for coronavirus, if a nursing home is experiencing an outbreak, or if a community is experiencing an outbreak of coronavirus. So this is pretty broad language right now, but it is good to see that we finally have a date that the department will need to provide us with some clarity around what can we do around visitation and kind of this balance between what CMS and what MDHHS is doing. We finally have a date where they have to give us some clarity, which is nice. There's also things in here about what we can do in terms of identifying laboratories for people to prioritize coronavirus tests for nursing homes. As I said before, there's the eligibility criteria in here for CRCs, or the care and recovery centers is what they're called. And then there is also one more thing I wanted to touch on here. And then there's also the process for the implementing what the criteria are for having a designated area within a nursing home to care for COVID folk or COVID positive individuals. So while this review was rather general and broad, I will have something more specific on Friday, and we'll have something in the newsletter this week. But just know that the legislature and the governor came together, negotiated this bill, and set a deadline of November 15th for a lot of information we've been waiting for a while. This bill was negotiated last night / early this morning and has passed the House and the Senate and is now moving to the governor's desk for signature. So since it was negotiated with her last night, well, it hasn't been signed, there's a good chance that it will be signed. The next most important bill for healthcare providers is the House Bill 6159. This bill provides liability protections for healthcare providers and healthcare workers that result from the COVID-19 pandemic. This bill was also taken up by the House. It had already previously passed the Senate, so it would move to the House. It passed the House and was negotiated between the governor and legislative leaders last night, and passed the House and is now sitting on the governor's desk. So there's a good chance that she actually signs this bill this time. She will not veto it. And actually, we've heard, I've been doing some digging, some investigating here, and we've heard that the negotiations went well and that she does plan to sign this. So fingers crossed, she vetoed it last time, but now is the best time and the best signs we've ever received regarding this bill. There's also was a couple of other bills that passed the House that aren't necessarily super relevant to us, especially like the first two. Senate Bill 866 deals with unemployment claims. If you remember, I think it was Friday, I mentioned that this bill extending the unemployment benefits had been barred to other liability protection bills, not the healthcare liability protection bills. Through the negotiations with the governor, they took away that tie bar yesterday. So what this means is that they can pass the unemployment bill separately from the other liability bills. And that was something that was done politically to kind of force the governor's hand to negotiate. But the removal of that tie bar shows us that they were actually negotiating last night, and that something will get done, and this bill is planned to move forward. It's on her desk, and I know she's very eager to sign this bill. The other two bills, Senate Bill 911 and Senate Bill 1108, are kind of more procedural things, allowing retirees from other state agencies to be rehired without them losing their benefits, and changes to the Open Meetings Act. Both of these passed the House yesterday after previously passing the Senate. So they're all on the governor's desk waiting for signature. All have been negotiated and all are likely to get signed. So we are kind of a good news, kind of a morning. Unfortunately, I do have to leave for another meeting. So if you do have any questions, I do suggest that you enter them in the chat right now as we move to the question period.
All right, thank you, Dalton. I do have a few questions for you, so we will go ahead and just get right into those. Somebody said, what is the meeting Deanna is hosting this afternoon? I believe that Dalton just meant that she'll be talking about it later in this presentation. Is that correct?
Yeah, I'm sorry, that's what I meant.
No, yeah, you're fine. Is that Senate Bill 1094 revisitation only for nursing homes? What about AL and IL that are covered under new MDHHS orders for outside only?
The bill specifically references nursing homes. As far as AL and IL, I don't think they have anything in that bill right now. I know there is a separate bill moving through the process for HFAs and AFCs. IL and AL have always kind of been oddly included and oddly separated at the same time from the nursing home policy throughout all this. So while there's no detail in this, the next steps will be to have these discussions with the department before November 15th to see, hey, can we keep everything in line here? Can we keep marching forward? So that's kind of our next steps for our advocacy as an association, making sure that AL and IL are included in these visitation policies.
Okay, what is the date that they need to respond about visitation?
November 15th.
Okay. Can Clergy have access to indoor visitation if a patient cannot come out and not doing so would result in harm to the patient?
The bill doesn't actually give us any specifics around what the policy is. It just says that they need to give us a policy by November 15th. So that question is kind of still up in the air, but we will find out shortly what they plan to do. And I'm sure we'll have some discussions with the department before November 15th to see what they're thinking and see if we can make some progress for everyone and help these things make sense for everyone.
This says, will other bill mirror 1094 for HFA and AFC?
It doesn't mirror it specifically, but it does kind of provide general guidance, and they are considered, at least right now, to be connected. And the other bill is it just passed the House. It still needs to go to the Senate, so it still needs a little bit more work. But they do in the other bill. I'm sorry, it was a late evening. The other bill does connect the HFA AFC stuff to the nursing home stuff, but it doesn't give us specific dates.
Does this bill also deal with isolation issues regarding appointments?
This is Deanna. There is new guidance about that coming up. We're going to talk about that later in the program.
Well, there we go.
All right. Do both Laura and MDHHS have to have policies for indoor visitation?
The bill says that they have to work together to create the policy. So I'm guessing the policy will come from MDHHS and Laura will follow that.
All right, sounds good. Thank you very much for that, Dalton. It looks like that was the last question, so we can go ahead and keep moving forward.
Okay, thank you, Dalton. We're going to focus for a few minutes here on Michigan data because there's recently been some concern and messaging from the department that we may well be moving into a second wave. And that, of course, could impact members as cases begin to rise. So next slide, please, Blake. So these are the Michigan statistics as of yesterday. You can see the average number of daily cases for the past 7 days was 1,125. That's pretty high and significantly higher than it was a couple weeks ago. The long-term care facility outbreaks are continuing, although they seem to be a little bit smaller, but the number of school outbreaks appear to be even larger than the long-term care at this point. So if that trend continues, there'll be a major shift in in where the outbreaks are occurring, obviously. Total nursing home cases with staff and residents total about 14,000 people at this point. So yesterday, the department reported in a press conference with Dr. Caldoun that there were some serious concerns that this could indeed be the start of a second wave. With that 7-day average of new cases climbing pretty routinely for the past 3 weeks, you can see that hospitalizations are increasing. There's a rising number of cases again among seniors, and the caseload for seniors was a lot lower during the summer. And test positivity rates are also rising from an average of 3% in June to 3.6% so far in October. So it looks like definitely the virus is spreading again, rather significantly. So when we look at cumulative caseload across the CMS Region 5 states, you can see that there's a more rapid rise in recent days, in fact, the last couple of weeks. Michigan's trajectory has always looked a little bit different from other states, but you can see that there's pretty much kind of a flattening or stabilizing a few weeks ago with recent rises all around us. So this is a new version of our standard graph. Remember that it tracks new cases using a 7-day rolling average, and this is just Michigan data, of course. So in order to put it in a little bit more perspective, we went back to including the entire COVID experience since March in terms of the data. Most recently, I'd only been including the last 60 days. So while, of course, we're not at peak levels, you can see that for the last couple of weeks, we have definitely been climbing higher. And though deaths seem to be fairly stable, you can also see a new rise in the recent couple of weeks as well. And remember, this graph too has been updated to include all the COVID experience since the beginning of the pandemic, so that you can compare time. On Monday, we heard some rumors from some members that Michigan was now considered high risk across the entire state. We've never been able to actually confirm that with anybody in authority. As of yesterday, we were running a 3.8% positivity rate, and that was an increase from 3.5% last week. A rise in new cases as well, rather significant, from 67.7 cases per million last week to 82.6. But as of yesterday, the map itself had not changed. So all this increased caseload ties into several conversations that we've had recently. About 2 weeks ago, we heard from a member that some local health departments were prohibiting outdoor visitation for their area based on some very strict parameters in terms of new cases and positivity rates. So we spent some time talking with the department, and they updated their visitation FAQs shortly after that to include what we considered much more reasonable parameters before the local health departments could be restricting visitation. But then again, yesterday, we received word through another member that a local health department had determined that the current department guidance continues to prohibit completely communal dining and group activities. So we reached out to numerous entities yesterday at the state, including the long-term care ombudsman, and pretty much the department, the long-term care ombudsman agreed that that was a misinterpretation, and so did MDHHS. But specifically what they said was, because what we asked was, is there a plan is that the plan, or is that the interpretation of the current guidance that's out there, which is now listed in one of the epidemic orders, to not have communal dining again? And they said, no, that's not part of their current plan. But then they added this sentence on the end of it, but that's not to say that things cannot change. And right now, with the increasing caseload, it's going to be interesting to see what happens as we move forward with legislative mandated visitation policies. CMS is still sitting out there for nursing homes with visitation requirements and an increasing caseload. So we've always noted a huge reluctance on the part of the state to consider visitation. We'll just have to see how all of this works out. Hopefully, we will be able to have some visits for our seniors shortly. So we're hoping. So we can pause for any questions now, but since we just did, Blake, you can move forward. Why don't we move on since we're running late, and then we can catch up some questions later. So resources and updates. We received a couple of requests from the department for some information from our members. So the department's looking to identify information requirements for any residents who might need to be relocated. So they're creating some requirements for a transfer packet between facilities, and they're interested to know what facilities might expect in terms of COVID information. So I would think that you would need historical testing data. I don't know if you need all of the historical testing data for a resident. Other than that, maybe any history of respiratory illness. I could not think of anything beyond that that would be COVID related that should be in a transfer packet. But the department did ask me if we could poll our members for any input. So if you have input or ideas about what you would need to know before you would accept a relocated resident, if that was required, what would it be? I'll give you a second. I don't know if there's, I don't expect a lot of variation in responses here, but we'll give you a second to respond to see if there is any creative ideas on your part. While we do that, why don't we move on to the next slide and give people a moment to respond if they choose, because we have another request for member input in the next slide, Blake. So this request for information came from the Long-Term Care Ombudsman's office, and they asked about voting. They're trying to guide facilities to promote access to voting, but they're not sure what current practices have been. We do know that CMS guidance suggests use of local and state programs to help with voting. But there's nothing in the guidance that says that facilities can help residents by actually transporting the ballots to the clerk's office. So the Ombudsman wants to know how ballots in general get to the clerk's office, and or if that isn't something that you usually do, what your plans are specifically to help people get their ballots where they need to go if there's not enough volunteers coming in with assistance programs that are taking care of this. So those are the two questions that we've had from the departments, the regulators, more or less, recently. Are we getting anything, Blake?
Yes, I was just waiting for you to conclude
Stop
that.
talking.
Yes. So I do have a couple things. One person said, is the transferring resident cognitively able to self-quarantine?
This is a general thing. So if that's what you need to know, that would be interesting. Yes, I think I think that might be covered in the rest of the packet, but it could be considered COVID related to, about what their abilities are in order to self-quarantine, if that's what the member is trying to say.
I believe so. If they are on dialysis or need to leave frequently for appointments.
That's good. Great.
And then as far as the voting, it would be nice if the clerk could be permitted to put up a temporary ballot box at a community.
Have they ever done that? Do they do that?
No, they do not.
Oh, okay. Okay. So how are there specific plans other than that, or have you had good experience with local assistance programs that really solve the voting problem for you?
I do have a couple more comments as well. Someone said, we transport residents to the ballot box location at City Hall. People do not want to mail at this time. And then...
Okay, so am I correct that no, go ahead, Blake.
And then I was just going to say one more thing. Maybe someone could be deputized to deliver for a facility, as it is illegal for anyone other than immediate family to bring a ballot. The assistance program.
Okay, that's what I thought.
Yeah. The assistance program does not get the ballot dropped off. We need the ballot to be delivered. And then that is the last thing that I have.
Okay, great. Thank you very much. Okay, some members have been communicating with us about burnout and are looking for creative ways to support their staff at this point. And so we wanted to take a couple minutes and maybe gather some creative ideas from our members about staff support, staff issues. The pandemic is wearing on everyone. It's been going on for a very long time. And so we wanted to know and share among members if there was anything new or creative that facilities were doing out there. Like, go ahead and move to the next slide, which is related to this, and I'll ask both questions at the same time. So as part of the staff burnout discussion, one of the big challenges that one of our members is having is that they're struggling with, the care staff are struggling with lack of time for actual resident care because they're donning and doffing and redonning and redoffing all day long, it seems to them. So we're wondering how big of a problem is that really? And along with staff burnout, how members are using their PPE, reusing and mitigating the shortage, and yet keeping within the infection control safety protocols. So is this a big problem? Are you able to, sometimes I know that you can reuse and you can keep your PPE on, but is there a big issue with time and staff and burnout over the fact that you've got to go in and out of isolation all day?
I'm not seeing too much come through. All right. We provide family and back-to-school packs of PPE, including gloves, masks, and hand sanitizer twice per month. Our staff greatly appreciates these efforts.
Okay. Well, if there isn't anything else, what maybe we should do next time is to go through PPE usage and how to reserve, because if you could reserve and reuse, sometimes you can also extend the use and perhaps not be changing as often. So we can consider that next time. So moving on, we also get a lot of questions about N95 masks. You can move, thank you. and fit testing. And I have to state that I am in no way conversant, really, in any detail with either of those. In fact, I'd never heard of fit testing personally before the pandemic. So the best I've been able to do is come up with a few resources about respiratory protection standards from OSHA, and those links are here. And our read of the rule says that certification for fit testers is not required, and that's a question that we get a lot, but that the person must be qualified by training or experience that fits the level of the respiratory care program provided. So the fit testing protocols, and there are many different kinds of protocols to actually test to make sure that masks are fitting appropriately. They can be found at this site listed at the bottom of the slide. So although there is no requirement for certification, there are certification programs, and we have listed a few of the major ones here without, of course, any recommendation. Also note that if you have problems with your respiratory program, your care program, or fit testing, that sometimes your local health department may be able to help you. They have people there that can help guide you to some resources and other things. So, keeping on the subject of PPE just for a minute more, HHS has just published a PPE Preservation Toolkit. It helps facilities track usage and also project usage down the road just as a resource. And the link, of course, is right there.
Just letting you know, I do have a few things popping in now that were a little longer, if you wanted to go over those.
Okay, sure, go ahead.
They take the gown off and hang it in the room to use it again next time they go in. So staff has a gown for each room that they use all day, which helps with saving some PPE.
Okay.
As much as we try to be positive and work creatively towards solutions, many of our staff and leaders are just done with COVID and the extra and conflicting rules. Staff don't want to work in these conditions anymore, so we're working hard to help encourage staff, but the regulations are squeezing staff and choking them. We're trying to explore an attendance bonus, and we've offered a once-a-week meal to staff for free.
Okay.
And then
It's been hard.
I have one more. I think how to deal with staff burnout is a big deal that people are not sure how to deal with. We have people who have had the pedal to the floor since February, March, and are still going and dealing with everything coming at them. I definitely think that any suggestions people have or ideas would be welcome.
Okay, we will try and look at that, maybe do something a little bit more formal about staff burnout and staff support.
Someone just said,
so we will.
We have a spirit committee to do special events for employees, food and little gifts, etc.
Great. Okay, moving on. This next slide is a screenshot of only part of the first page from a 2-page handout that MDHHS put out. It summarizes the October 9th epidemic order. So we're not tracking executive orders so much anymore, but we still have to attend to these epidemic orders from the department. So this is a pretty good summary of the recent October 9th guidance for indoor and outdoor gatherings and requirements. So we thought it might be helpful. The link is noted here, and it's a 2-page, both sides. This is only part of it, but it pretty much does summarize what the gathering requirements are at this point. And you're probably all aware that several weeks ago, the CDC issued a temporary halt to evictions as a safety precaution. HHS has now released a formal rule within the Federal Register, along with some FAQs. And those FAQs mostly speak to the need for eviction candidates to complete a declaration form. And all of those links for those items are listed here. A fairly important study was released last week in the Journal of Clinical Infectious Diseases. They found that the coronavirus can live for up to 9 hours on human skin. that's a lot longer than anybody, I think, anticipated, compared to about 2 hours for influenza viruses. Previous studies showed also that it can live up to 4 hours on copper surfaces, 24 hours on cardboard, and up to 72 hours on plastic and stainless steel. So there's a huge focus here on continuing hand hygiene and disinfection of surfaces as critical infection control elements. So before we get to the nursing home only content, we wanted to provide a list of upcoming dates and targets. Many of these dates here are related to state level grants and the DCW, the Direct Care Worker Pass-Through. We are going to be publishing these in our next COVID update as well. One thing I want to focus on is 1016. There is an informational webcast on the, it says 16, but that's an error. That's 15th. At the top, you can see October 15th at 3 p.m. There's a Provider Relief Fund informational webcast. And the link to that is there, 3 o'clock tomorrow. And I will fix that on the grid. And also, amazing to me is that the CRC applications to the department are due on the 16th, which is an extremely tight time frame considering they just put out the guidance. We're going to talk about the CRCs just briefly a bit more later in the slide presentation. So pretty much from this point on, we're going to be talking about things that pertain to nursing homes. We have been getting all along several requests for names of infection control specialists. And we know that they're needed for directed plans of correction related to infection control. And although we keep asking, we've never really been able to create a list. So we reached out to Laura, and they provided these sources. Two of these, of course, are the QIOs, and of course, Pathway is a private consulting firm, healthcare consulting firm. It appears in practice that most of the specialists that people are using are coming from these organizations. So last week we discussed the criteria for care and recovery centers, and the department has issued its guidance and is asking for applications at this point. And again, the applications are due October 16th. And to be honest with you, I can't imagine they're going to get a whole lot of applications with that kind of a due date, but we'll see how that goes. Here are the draft. And these are just draft financial funding methodologies that they plan to use. So you'll see that indeed payments are much more generous than they were before for CRCs. And in addition, the department will provide a monthly stipend so that if there's a fluctuating census and it gets hard to keep the unit open or at least cost effective for providers, they'll be providing a monthly stipend to help that. There's still no word on legal immunity. Of course, we do have that other bill out there in the legislature. And with the new bill that was just passed yesterday, but not signed, we'll be going through that in detail and seeing how that and the department's current requirements align. And we'll probably be talking about that a little bit more on Friday. So attached as a handout today is a copy of Laura's guidance to surveyors for resident-related infection prevention and control scenarios. This is the guidance that we've been talking about, anticipating really for several weeks. I call this the cohorting rules, more or less, and when providers have to cohort. And we know that a lot of people have gotten cited for not cohorting certain groups of residents, and that has been a problem. So Laura states that this guidance is really meant for surveyors, and so it's not for providers. It is not intended to necessarily give you every rule that the surveyors are going to have to follow as a provider, but it's supposed to be meant as information about how they're interpreting the CDC guidance now, and you will see that there's some big and important and positive changes here. So we do suggest that you read and review, of course, the entire resident scenario document. It starts with a discussion about source control. And basically, we all know persons should all be wearing masks if outside their room if tolerated. One of the first sections does talk about masks for persons who are in transmission-based precautions when they leave their room. But when in reality, we know that persons in transmission-based precautions shouldn't be leaving their room. It should be a rare occurrence, but it is in the document. They also list 2 of the F tags for infection control, and that facility programs must be based on a national standard. And that pretty much means the CDC. And once that's done, you'll be held to that national standard, along with any requirements from CMS, of course. And then the second reminder is that each facility assessment and resulting emergency plan must reflect COVID issues. Anticipate that during your surveys. So then we get on to the actual scenarios that they have documented. The department's created several. The first is for COVID positive persons. And this is self-evident. They can be placed in a single room, or they can be cohorted only with other COVID positive residents and placed in a specific COVID dedicated unit. That is really the expectation. If a resident has been exposed to a COVID positive person, hasn't necessarily tested positive at all, has not tested positive, and that exposure occurred outside of the facility, again, they can be placed in a single room, restricted to their room, and placed in a separate observation area when possible. It doesn't say that they have to, at all times, be in a separate observation area, but they should be if it is possible. The third scenario, scenario C, is for known exposures for staff and residents that occurred inside the facility. So now the exposures occurred from an outbreak. Residents who may have received direct care from an infected person must be observed, obviously, for 14 days. The document actually says that they do not have to be placed in transmission-based precautions, but that all PPE must be used. That really doesn't make sense to me, and it's pretty much contradicted later. So I would definitely be placing persons who have direct contact to a known positive in transmission-based precautions. For residents who are exposed to other residents who are positive, the affected resident must, of course, be moved to a dedicated unit. The roommate should be considered exposed and cannot be rooming with any other residents in the interim. They must be observed for 14 days after exposure and restricted to their room. Any resident who has been exposed must be restricted to their room as much as possible and observed for 14 days. For new admissions, the guidance says they must be quarantined for a full 14 days, either in a single room or an observation area. Again, I think an observation area is preferred, but not required. If they've been asymptomatic for that time, they can transfer out. So for all these scenarios discussed, A through D, if the person was COVID positive, or if they were exposed in some way, or if they were new admissions, full PPE must be used for staff, and that includes N95s, and they're preferred, although there is also a recommendation to optimize equipment use if you have to. So in reality, you have to treat all of these persons as if they were in transmission-based precautions, but they have loosened the requirements for observation units. And here's the really important update. Persons with routine or frequent external visits for medical purposes are not required to be either under transmission-based precautions or in an observation unit. They do, the department, meaning they do ask facilities to consider this, however, if caseload is increasing in the community around you. So you need to use your judgment about what you think your risk is, but it's not required for everyone. And for those who leave the building infrequently, they suggest first reliance on telemedicine when possible. But there's also no requirement to place in an observation unit or place them in transmission-based precautions either, but they should be closely monitored for 14 days. So Laura ends with some final notes. They define known exposure as a close contact, and I think we're all familiar with that. They also recognize the difficulties with keeping masks on persons who have memory issues and suggest that for those kinds of persons and those kinds of units, there remain a strong focus on hand hygiene and social distancing for that group. And they also refer to the CDC resource for memory care units. So finally, we've gotten some guidance that appears to be positive for dealing with those persons who have routine appointments. And I have to apologize, my asthma is kicking up pretty bad, so that's why I sound so hoarse. So I hope I'm communicating okay. Questions or anything, Blake?
Yes, we do have a decent list of questions here, so I'm just going to get right into them. I'm just going to restart. Are the POC antigen test results having an impact on positivity rate? Some counties do not require the report of negative results, only positives. This would impact the total number of tests being performed.
That's a very good question, and I don't have a good answer for that. I've often wondered about that. I had thought that the total number of antigen tests would have been calculated from the NHSN data. But local health departments, to my knowledge and based on a guidance from MDHHS, they only request the positives. I have never gotten a confirmation about how that makes sense, but we can forward that question again to the department. I do think I asked something about it once before with a set of other questions, but I don't think we got a good answer.
Okay. In our communities, would we be considered residential, correct?
Yes.
Okay. Epidemic order of October 9th limits up to 10 persons indoors in residential gatherings. Would this include the dining room of IL?
Settings. I had always, when all of that was in an executive order, and I have not looked at it in the same light as it's an epidemic order, we considered that healthcare settings, which would include residential independent living settings in that group, were not really included in any of that part of that epidemic order. So the October 9 epidemic order, and I think executive order, I don't remember the number, was the previous executive order that covered that. I did have a discussion with the state about the lack of clarity about where healthcare settings and senior residential settings fit in that. When they use the word residential, they usually mean a house. They're not talking about a congregate residential setting for senior care. And generally, those settings are not included in that guidance. However, that's another thing that we can ask as we move forward to get better clarity about that. And in fact, I did once, but that was one question that I've not gotten a response about.
Okay. Regarding facility assessment and plan, should we revise the current one or include as we move into the next year? We use this quarter to evaluate and develop for not the next year.
Well, I think that if you don't have something in your facility assessment right now and your emergency plan now about risks from COVID, that you're probably not in compliance. You are supposed to redo that facility assessment and plan whenever there's a significant event. And I think everyone would agree that COVID is a significant event. Now, you might not have a problem if you don't have a surveyor in your building in the near future, but technically your plan should be up to date now with COVID.
If a resident leaves for an appointment and returns, do we have to keep the resident in quarantine and staff wear N95s?
No, that's exactly what the new guidance, although it's not supposed to be guidance, it's supposed to be information for the surveyors, but that's what that document says, that you do not have to do that. You do need to monitor them closely and make sure that they're not developing symptoms and that their vital signs and everything's stable, but you do not have to quarantine them and you do not have to put them in transmission-based precautions.
For residents going out to an appointment, do they need to go? No, that's the repeat question. Under scenario D, it says status unknown. So can we safely assume that if we have a negative COVID test within 72 hours of admission, we would not need the private room and 14 days observation?
No, you cannot assume that at all. They're not going to accept that. When you get a negative test, that is a negative test for a point in time. The incubation period, we all know, can be up to 14 days. A person could test negative on day 2 and be positive on day 4. So unless you're testing every day, which we don't suggest in any way, shape, or form, you really don't know whether or not that person's COVID-free until they've gone 14 days without any potential exposures. And they consider a new admission coming from the outside, whether it be a hospital or somewhere else, as potentially exposed. So no, you have to keep your new admissions and your readmissions in quarantine for 14 days with full transmission-based precautions.
How are they recommending a different 14-day monitoring from what we normally do? I would guess more TPR monitoring.
Yes, just keep an eye on their symptoms, check in a lot. Some facilities do pulse oximetry. I'm not sure that's required for someone who doesn't show any sign of respiratory distress, but monitoring, checking in with them, making sure that they're not exhibiting symptoms and that they're not, saying that they feel ill.
Okay. If we do all 14-day TBP and all private rooms and no longer have to have a separate unit for them to cohort, where does this leave us with the similar need to have a segregated COVID area for those patients who subsequently might test positive for COVID while in their 14-day TBP stay?
Okay, if I'm understanding this correctly, you're talking about setting up individual, private, potentially isolation rooms that could include COVID and non-COVID persons together. And that would really not meet the requirement for a dedicated unit. A dedicated unit has to have a separate entrance. You don't want people who are traveling through non-COVID units and taking care of COVID patients. You are supposed to have dedicated staff that aren't moving through the facilities. So I don't think that would meet the requirements for a COVID unit.
Should the residents in transmission-based precautions quarantine but are not symptomatic? Can they leave their room for therapy with a mask on?
I'm sorry, say that again.
Should the residents in transmission-based precautions, I don't know what D/T means, base precautions, DT, quarantine, but are not, due to quarantine but are not symptomatic, can they leave their room for therapy with a mask on?
Okay, I'm assuming number one, you're talking about persons who are not in transmission-based precautions because they've tested positive. I don't believe that they can, no. I think that some people have been doing therapy in room, but I don't think those persons are supposed to be traveling through the building either until their COVID status is known.
Okay, just to be clear, I heard the state is not requiring fit testing, but rather a policy for respiratory protection with competently trained staff.
That would be great. I'm not aware of that. I do know that I base what I look into on questions that I get from members, and I get a lot of questions about fit testing. So if that's the case, I think that's excellent because there's an awful lot. I was overwhelmed by the rules about fit testing. I couldn't imagine that we could be effective in doing that very easily.
How are facilities conducting outside visits? Are they using tents?
I can't answer that. I don't know. We do have a question out to the Department of Bureau on Fire Safety Services to talk about what the requirements for a tent might be. And we refer people to their local health department to consider whether or not heaters are allowed, which I don't think in general they are. But I don't really know what members are doing. So it's running a little bit late. Maybe that's a question we can answer at one of our next webinars. Some webinars we don't have quite as much content.
Has there been any more clarity in regard to testing frequency with MDHHS?
I don't, if I understand the issue correctly, I don't think it's unclear. I think that it's clear that you must continue to look at your regional area positivity, and you must, I would say in all parts of the state right now, be testing weekly. The confusion, if anything, comes with CMS. You have to meet the CMS guidance, and if you can meet this, both of them, you have to meet both of them. So the fact that the CMS guidance is for less frequent testing doesn't mean that you don't have to test weekly. I don't think the department thinks that's unclear at all. They want you to test. They believe that that's the only way that we're going to know what's really going on and able to act quickly enough to stop the spread.
Okay. Can you explain the people that leave frequently for dialysis or appointments part again, and if they need to be quarantined?
They do not need to be quarantined. They don't need to be placed in transmission-based precautions. Although, if you think that there's high risk in your area, that's an option that you could apply. Additionally, dialysis patients have a high risk for getting the disease and for having really significant negative outcomes. So you should be paying close attention to those persons when they move in and out of the building. But right now, if you don't have a lot of transmission around your facility, and I would be communicating with the dialysis center to make sure that they don't have any COVID there or haven't had any COVID there. I would use that information to judge whether or not you should perhaps put some of these people in transmission-based precautions when they return, but there is no requirement that you do so unless there's a reason.
To whom do we have to report cumulative COVID positive cases? Is it just, in our case, Wayne County?
Well, you have to report your cases to your local health department, and of course, if you're a nursing home, to NHSN.
Okay, so does every skilled nursing center have to have a COVID area just in case someone tests positive?
Every nursing center is expected to have a plan to cohort if they have to. If you can put together a dedicated unit, some facilities simply aren't designed well for that, or their units are not large enough to really make that work. So it's harder for some than others. But you, at a very minimum, you have to have a plan what to do if you have an outbreak and a surge in your building. That's number one. Number two, you are supposed to work toward having a dedicated unit if it's possible.
A separate unit is only needed for COVID, correct? Not the yellow zone for new admits and TBP. Yellow zone should be a separate area wing, but not necessarily a separate entrance.
If you can set up an observation area, I don't know that they need a separate entrance, but you wouldn't want traffic flow to be going in and out of there all of the time. I think you would have to look at your individual footprint and figure out how traffic moves. But you need to think about your exposed unit in a similar light as your other units, even though it's a little bit different, because the potential for COVID being there is there. So you have to think about that. I don't know that you need a separate entrance from the outside. I do know that you need to look at your traffic flow.
Can we put up a freestanding shed or garage for outdoor visits?
I think some people have done that. My only concern would make sure that there was adequate ventilation and protection from the weather, no matter what kind of structure that you have. Ventilation is like really, really important, and that's why the department focuses on outdoor visits rather than indoors. It's all about the ventilation issue. If you have an enclosed space, it's a shed, and air can get trapped in there and be very stagnant. So you need to be very careful with these temporary shelters that you have enough ventilation, because when you don't have enough ventilation, that's the time when COVID can get airborne.
Okay. We collaborated with our local fire department on the tents. They told us as long as the tent was fire rated, we could use a heater in them, and recommended we rent them from the same place we rented the tent from. Local fire came out and inspected the tent and verified we were putting them up in a safe place that allowed for access to the fire lane and hydrants.
Great. Sounds good.
Is the option to not isolation precaution dialysis patients the same for all the patient appointments outside of the building?
Yes. If I understand correctly, you do not have to isolate anyone who is currently a resident in your facility simply because they're moving in and out of appointments. So it really pretty much depends on whether or not you feel that these persons are at even higher risk because of high community transmission, that they should perhaps go into some precautions, and that's the same for dialysis patients. The dialysis issue is only that they are at higher risk for severe illness if they should become infected.
If you have no COVID positive cases currently, don't you have to report your cumulative cases on a weekly basis or not?
Yes, that's my understanding.
All right, sounds good. Thank you very much for that, Deanna. It looks like that was our last question. So as always, if you do have something that pops up in your head after the webinar has concluded, feel free to reach out to Deanna, Dalton, or the Safe and Calm email, and we will make sure that we get all of those answered for you. Other than that, I think that takes care of everything, and we would just like to thank Deanna, thank Dalton, and then obviously thank Robert for joining us today. I believe we also broke our record in attendance today, and I believe we're around 105 members and participants that took time out of their busy schedules to join us for today's webinar. We appreciate everything you guys do each and every day to support your staff and provide quality care to your residents. We are grateful for your continued support, and we are here for you when you need our assistance and resources. Our next webinar will be this Friday at 11 a.m. Eastern Standard Time. So other than that, I hope everyone has a great remainder of their Wednesday, and we will see you then. Thank you.
Thanks, everyone.